This is part 2 of the physiology of ventilatory support. We're going to talk about minimizing adverse effects of positive pressure ventilation. To minimize those effects, we really need to be concerned about the pressure. Attempt to keep the pressures as low as possible, and specifically the peak inspiratory pressure, less than 40 centimeters of water, and the plateau pressure less than 30 centimeters of water. Other options are use of diuretics, bronchodilators, inotropes. You may need to decrease the tidal volume to keep the pressures low, or you may need to decrease the PEEP also. High mean airway pressure can impede venous return, reducing the cardiac output. Recall that mean airway pressure has a good side and a bad side, and that bad side is decreasing the cardiac output. Use of PEEP and CPAP. This is used to improve oxygenation, particularly with refractory hypoxemia. Refractory hypoxemia is defined as PaO2 less than 50 to 60 on an FIO₂ greater than 50. PEEP maintains open alveoli, increasing the FRC and reducing shunt, often improving static compliance and the PF ratio. The PEEP allows the FIO₂ to be reduced while maintaining a reasonable PaO2. One thing that we need to understand is sometimes we can live with an increased CO2 because of the compensation that occurs, but we can't always tolerate a lower PaO2. Table 43-2, beneficial and detrimental effects of PEEP. For the beneficial effects, you have restored FRC and alveolar recruitment. You have a decreased shunt, increased lung compliance, decreased work of breathing, and an increased PaO2 for a given FIO₂. The detrimental effects increases incidence of pulmonary barotrauma, potential decrease in venous return, increased work of breathing with overdistension, increased pulmonary vascular resistance, increased ICP, decreased renal and portal blood flow, increased dead space, and increased mean airway pressure. The effects of the ventilatory flow pattern. The square waveform typically of volume control ventilation, and the decelerating waveform typically of pressure control ventilation. Compared to the square waveform, you have a decreased peak inspiratory pressure, a decreased plateau pressure, decreased work of breathing, decreased dead space, decreased CO2 level, increased PaO2, and increased MAP. With low flows, this can cause air trapping, as we're talking about the waveform. Remember, anytime you talk about the waveform, you also have to consider the peak flow. If your peak flow is too low, then what happens is that eats into your expiratory time, and it may not allow the patient enough time to exhale. So many times you've got to be concerned, is our flow high enough? And do they have enough time to exhale after we deliver the tidal volume? The physiologic effects of ventilatory modes. Volume control versus pressure control. The primary variable we wish to control is the patient's minute ventilation. Continuous mandatory ventilation, or CMV, provides all breaths, even patient-triggered, as mandatory breaths. Mandatory breaths may be volume controlled or pressure controlled. Volume controlled modes. These provide all breaths, even patient-triggered ones, as mandatory breaths. In other words, the machine is responsible for delivering the tidal volume at all times. The patient may trigger breaths, but the machine is responsible for delivering the tidal volume. So breaths at set tidal volume, but the pressures will vary depending on the lung mechanics, the resistance, and the compliance. In volume control, you'll have higher mean airway pressures. For true control, patients must be sedated. In other words, if the machine doesn't allow assisted breaths, for the comfort of the patient, they would need to be sedated. The problem there is muscle atrophy because they're not using their muscles. You must set a trigger and flows to meet the patient's need. Otherwise, asynchrony occurs, and you can typically see that in the graphics. In volume control SIMV, used for patients capable of providing some ventilation, the mandatory breaths will all be at the set tidal volume, but all other breaths are spontaneous. The advantages here are it avoids atrophy of the muscles, has a decreased mean airway pressure, and a reduced risk of cardiovascular compromise. Typically, the set volume and the spontaneous volume are different in size, with the spontaneous volume being less. There's a couple of reasons for that. One is that the patient may be weaker, and so they're unable to take a big volume on their own. Secondly, pressure compresses gas and occupies less volume. Some of the ventilator circuits are compliant, so under pressure they expand, which causes a volume loss. This is not particularly important unless you're using extra small tidal volumes. You minimize this by using low compliance tubing and a low volume humidifier. Compensating for this loss, this tidal volume loss, is you may have to adjust it manually. In other words, if you're losing 150 mLs of tidal volume due to the circuitry, then you would just increase your tidal volume by 150 mLs, and then you could deliver the amount of volume that you wanted. Let me give you an example here. Example, let's say we start out with 500 mLs as the delivered tidal volume. And we're going to whittle this away with, we're going to lose some with tubing compliance. And so that's dependent on peak pressure. The peak pressure multiplied by the tubing compliance gives you the volume loss depending on the pressure. Then you have dead space, which is associated with everything between the mechanical ventilator Y and the ET tube, and including the ET tube. And so let's say that makes up 150 mLs. I've actually measured that in a lab before, and that's pretty accurate for the suction catheter and the HME and the SVNT. That's pretty close to 150 mLs. So then any physiologic dead space that you might have takes away some more of the tidal volume, and so what is left over is alveolar volume. And so you see here that it whittles away pretty quickly, and sometimes can be substantially small if you're starting out with a small tidal volume to begin with. So some of the more modern ventilators have this feature built in where it actually measures tubing compliance when you do the calibration test, and then automatically feeds in the amount of volume loss due to tubing compliance each breath. So then if you have 500 set on the ventilator, well, at least the machine is not eating up any of that 500. The dead space, anatomical and physiological will, but nothing related to the tubing compliance. In addition, you may have some leaks in volume ventilation. And in volume ventilation is where it's important. In pressure ventilation, it's not quite as critical, but in volume it is. There's a couple of ways that you can identify this, where the inspired tidal volume is significantly greater than the expired tidal volume as you compare those two. In other words, if let's say your set tidal volume is 500, but your exhaled tidal volume is only 300, well, 200 of that is being lost somewhere, whether it's out the cuff, down the chest tube because of a pneumothorax, or maybe we've left some connection loose after we change circuitry. For some reason, we're losing 200 mLs. And so that part is not counted as ventilation. It doesn't participate in ventilation. So it's just lost volume. Another way is an abrupt above the baseline into expired volume as seen in the volume time scaler. So we'll pull up some more graphics here and I'll show you what this looks like on the graphics. Right here you see that it doesn't make the transition all the way back to baseline. It's almost like it skips to the next breath. And so that's what a leak looks like. So you see this is the drawing out of your book, and you see it where it doesn't make it back down to baseline. It looks like it just skips to the next breath. Actually, that's a leak occurring, and typically it will occur with every breath. You know, in some cases, if it's a cuff leak, you may not have a leak that occurs on every breath. Occasionally you'll have one and you'll be able to identify it like this, unless it's a significantly small leak. Pressure control modes. All pressure control modes feature patient or time triggered inspiration. Pressure limited inspiration, which is particularly important if your plateau pressures are high. They also feature decelerating waveform and time or flow cycled to expiration. Now let me show you what flow cycled means. Remember, cycle means to terminate the breath. If you have a flow cycled breath, I'm looking right here, you see that we're watching the flow. When the flow gets down to a point where it's, you know, in the area of 25% of peak flow, then the breath is cycled. Some ventilators actually allow you to adjust that cycling percentage. Some of them are just built in, but some of them will allow you to adjust it. Benefits of pressure control include limitation of alveolar pressure and improved patient ventilatory synchrony, possibly improving distribution of ventilation, oxygenation, and gas mixing. The limitation of the alveolar pressure. This is if you want to keep your alveolar pressure less than 30, then you have to set your pressure less than 30, because that's what's going to be the alveolar pressure, whatever pressure you have set. Pressure control, assist control, may reduce peak inspiratory pressures and alveolar pressures. On every breath, it has a preset pressure, so you have a constant peak inspiratory pressure. The volume and flow will vary depending on the lung mechanics, such as static compliance or resistance. This mode is typically used to treat acute lung injury or ARDS type patients, and may include lung protective strategies with permissive hypercapnia. Let's talk about permissive hypercapnia for a second. Permissive hypercapnia is a lung protective strategy where we are unable to ventilate the patient and achieve a CO2 that is normal without potentially causing harm to the lung tissue itself, whether it's barotrauma, volume trauma, causing a pneumothorax, causing blebs, whatever. So what we do is we allow the CO2 to rise, hopefully slowly, and understanding that the pH will compensate eventually. And so this is thought to reduce the risk of further lung injury associated with the barotrauma, using pressure control and inverse IE ratios. This is where your inspiratory time is longer than your expiratory time. This increases your mean airway pressure. Remember, the mean airway pressure is just the average pressure across a single breath. This is suggested to treat severe hypoxemia when a high FIO₂ and high PEEP fail, as in the compliance diseases like ARDS or ALI, acute lung injury. You have, in these diseases, you have short time constants, because typically the airway resistance is reasonable, but the compliance is really low. And so you have very short time constants. So low expiratory time is required here. And basically what happens, because the compliance is so low when it's time to exhale, basically the lungs just want to slam shut. Depending on the degree of IRV, you may cause auto-PEEP. And so many times we use that to our advantage by increasing the mean airway pressure and increasing oxygenation. If applied PEEP in conventional ventilation is equal to the total PEEP and IRV, oxygenation will be equivalent.